really impressive data, and it's amazing how we are innovating, meaning that how we're going to change our approach to PAD and CLI. We are going more towards pharmacotherapy rather than devices. So related to this, I wanted to start with this case to highlight the limitation of our approaches. So this is a 65-year-old gentleman who came to us with end-stage renal disease, diabetes, hypertension, all the good stuff, known PAD, and had this kind of a presentation. This level of necrosis, there is avulsion, there is dependent rubor, and multiple risk factors. So we did a ABI and a PVR, and ABI is 0.55. So we said, you know what, this patient has PAD, multiple risk factors, dependent rubor, we gotta do something. We take the patient to the cath lab. And everything looks great until you get to the kind of a below the knee, mid-tibial vessels. And here you see that you have this artery which appears to be peroneal, but ends up to be a dominant peroneal that becomes the PT. This took us a while to figure out, by the way. This was 1 hour of work, just figuring out that that was a dominant PT. But importantly, you see there is no targets in the foot. This patient is not a surgical candidate, and we know that if we don't improve the blood flow and we go after that toe, we're gonna get into trouble, because we're gonna start with a toe, end up with a ray, then a TMA, and next thing you know, below knee amputation. So we said, you know what, let's use some of these techniques that we have learned and see if we can try to improve the perfusion in this patient. So we worked hard, and we took what I showed you before and created this. I was very excited about this, Dr. Banerjee. Actually, I was gonna send the pictures to my mom back home, because she always complains that I send you to the United States to become a doctor and you became a plumber, because I always said I'm a plumber. But as I told my secretary to get the pictures ready for me to send it to my mom, unfortunately, the patient came back. And I don't know why patients keep coming back, follow up, a patient came back, and I was like, oh my God, what happened here? I worked hard. It looked good. I didn't do atherectomy, so I know there was no embolization. I just did angioplasty. And I learned that, yes, this is not unusual actually. A lot of these lesions, after you improve the blood flow, they demarcate. So some of it is a natural progression of improving the blood flow, is demarcation. Some of it is that maybe I cut off some collateral flow. But at the time when I saw this, I was like, you know what, I gotta look into this and understand what's going on. So I repeated the hemodynamics. Remember, pre-procedure, the patient was 0.55. After the procedure, the patient is 1.04. So I did great. I doubled the ABI to normal. But I knew that the blood flow issue was at the level of the distal foot, not the ankle. Because remember, the ABI only gives you information about the blood flow to the ankle and not the distal foot. So I went after the TBI. Before the procedure, the TBI was 0.24. After the procedure, the TBI is 0.16. And I was like, wow, that's crazy. So I said to one of my former fellows, who is now a big shot, he may be here in the audience, Dr. Bunty, and a couple other ones, I said, you know what, we gotta go look at the hemodynamics and look at our patients. How many of these do we have that we thought we did a great job, but yet the distal perfusion is not great? Unfortunately, this slide didn't come out right. I don't know why, but bottom line of this slide is that 30% of the patients with significant CLI, meaning that no straight inline flow to the foot, have a normal or non-compressible ABI. So number one lesson is that ABI is very limited when you're dealing with CLI. If it's abnormal, great. But if it's normal, you can't say that the patient has good blood flow. You have to look at something else, TBI, TCPO2, maybe our shark winner, FlowMeds, the group that won the shark tank competition last night, maybe a technology like that can assess perfusion. And actually, this work was done by Tarek, who is here, one of my former residents, who is now a fellow. And then we said, you know what, let's go back to our patients and see what the change in the TBI is after complex intervention. And honestly, this really surprised me. This really, really surprised me. The normal TBI, mind you, is anything above 0.7. So in 150 or so patients who started with a median TBI of around 0.2.5, after complex intervention, and I consider myself at least average, the TBI only improved to about 0.3. So the incremental change in the TBI after complex intervention was very, very small, and indeed almost none of the patients had normal blood flow to the foot. So while we do a great job with the macrovascular, we learned that we are not doing a great job with the microvascular, and this information actually predicts reintervention. So if your TBI doesn't improve by more than 0.275, that means that you're going to need a reintervention. And basically, this led us to this idea that can we supplement macrovascular reperfusion with microvascular therapy? Meaning that we know we can do a good job with macrovascular, but what can we do about the microvascular? Because we have this issue. We really cannot improve those little blood vessels in the foot. So we did this trial that I presented at ACC, and basically the concept was that can we use a biologic therapy, in this case JVS 100 or STF1, which is known to do all these things, promote repair, promote new blood cells, prevent cell death, and heal scar tissue, and multiple animal studies and also human studies to see if that we could combine these two to try to heal these ulcers faster and improve blood flow to the foot. So we enrolled 109 patients from 21 centers across the United States. It was a double-blinded, randomized clinical trial. And these are the centers, really grateful because it's very hard to enroll patients in the CLI studies. We had a steering committee, independent data and safety monitoring board. We had an independent statistical analysis and a wound core lab adjudicated laboratory. So we were pictures taken, all went to a core laboratory, and the primary endpoint of the study was actually wound healing. So the inclusion criteria for the study was the presence of a chronic wound of greater than 2 weeks that met one of the perfusion criteria, and then the patient underwent a successful revascularization. So we actually wanted the patients to have good macrovascular revascularization. After they had a good macrovascular revascularization, they were then had a perfusion assessment. If after macrovascular revascularization, they still had lack of good blood flow as measured by a TBI of less than 0.51, then they were randomized to STF1 or placebo. And we included end-stage renal disease, osteomyelitis of heel ulcers, and complex lesions. Basically, we started with 167 patients and ended up with 34 patients almost in each arm. These were the sites of the injections in the foot and in the lower leg. And the way we defined primary endpoint was based on a staging of a 5 to a -5. So a complete wound healing was 5, and if the wound got bigger by 25% or patient had a major amputation, it was -5. There were a number of safety endpoints such as male and others. For the sake of time, I'm just going to skip this, but I think you can see that the baseline characteristics of the patient, good number, about 10% had end-stage renal disease, 80% of the patients had diabetes, 80% diabetes. And you can see we had a good number, I would say about the 10% of the patients had heel ulcers, which are typically excluded from these kind of trials. And the ankle brachial index, as I told you, in known patients with significant CLI, well, look at this, is near normal. So you can't really rely on the ABI, but look at the TBI, 0.26, 0.27, 0.26. So remember the limitations of ABI. But this was what we found, and this was really surprising to us. So we found out that in each group, only 25% of the patients healed by 3 months. So in a vigorous trial, selecting very carefully the sites, doing macrovascular revascularization by some of the experts in the field, only 25% of the wounds healed at 3 months. And actually about 25% in each group got worse, despite successful revascularization. Unfortunately, there was no difference between the groups in regards to healing. So the drug, this therapy, the biologic therapy, did not work. But I think we learned a lot that only 25% of the wounds completely healed at 3 months, and actually about 20% got worse, at 3 months. And if you look at the TBI, again, it highlights the limitation of what we do as a macrovascular operators. So pre-procedure TBI was low. After the procedure, there is some small incremental change, but that did not improve with SDF injection. So we were not able to improve microvascular circulation. So anyway, there were a number of limitations about this study. One of the challenges with biologic therapy is that it's hard to prove that it's working. And this is one of the challenges, but I really think that we need to think this way, either with pharmacotherapy or with biologic therapy, because even though we're doing advanced macrovascular work, is not enough. We need something else to help us with the microvascular. Anyway, with that, I'm going to stop. Thank you very much for your attention. Thank you.